All right, everyone, if you're joining us, we are just waiting for a few more folks. We will get started at just after noon, so about 12:01, we'll go ahead and get started. All right, well, I see a few folks trickling in, and I see some time that we can go ahead and get started. So my name is Suzanne Heritage. I serve as VP of Communications for Central Texas HIMSS chapter. So we are thrilled today to have Katherine Lusk join us for our September Lunch and Learn. We will give an intro and everything a little bit later, along with just a high-level overview of the topic before we jump in. But I did want to go ahead, as folks are trickling in, wanted to go ahead and offer up some general announcements from the HIMSS Central Texas chapter. So if you're new to HIMSS, or maybe if you have recently joined your organization or you're a longtime HIMSS member, one of the things that we have been focused on as a HIMSS Central Texas chapter is really trying to drive engagement of our different members, whether that's an individual member, student membership. And so wanted to encourage folks, is your organization an organizational affiliate or academic organizational affiliate? So if that's new to you, or if you've never heard of the OA or AOA program, those programs were created in 2007 for the OA, 2013 for the AOA program. And really the goal is to offer organizations and academic institutions an opportunity to get their staff engaged with HIMSS. So if your organization is an OA, a healthcare related provider, health related entity or agency, and there's a wealth of opportunities that come with being an OA. So that includes things, I included a couple, these are just the highlights, but there's definitely a lot more. So complimentary membership for your entire team. So exclusive access to things like chapter membership, committees, task force, as well as exclusive events and conferences that are specific for HIMSS members. So we really encourage everyone, if you're an organizational affiliate, to please promote the HIMSS membership, HIMSS Central Texas, to your staff. We would love to get more staff engaged and really level up across the board. So, and similarly, if you're an academic organizational affiliate, HIMSS created this so that way students can get engaged at an early stage process and really provide education and resources related to health and care information and technology. So really cultivate that future health IT generation. So That also comes with unlimited memberships for students. There's 5 complimentary memberships for faculty. And again, same level opportunity around specific member exclusive access for HIMSS related events, conferences, and networking member opportunities. So we went ahead and included, you can see the link to sign up. There's a specific sign up link. Encourage you all, we'll send this, drop this in the chat here shortly as well once we get started. But we do want to make sure that please promote this across your members, across your staff. And if you are interested and wondering if your organization is an organizational affiliate or academic organizational affiliate, do go ahead and sign up. Make sure to use either your work email address for the OA sign up or the your student email that's administered by your academic institution for signing up as well. And if you're not sure, feel free to reach out. We went ahead and included our member email here as well, and we can help you determine if your organization is included as has an OA or AOA membership as well. Next big news, I would say, that we wanted to celebrate with folks on this webinar is that we're thrilled to announce that we, as the HIMSS Central Texas chapter, our collective we were recognized for the prestigious Changemaker Status Award, so through HIMSS National. So this is the highest level of advocacy recognition offered by HIMSS. So kudos to the members organizations, kudos to prior board members, to folks on this call. Our commitment to excellence and dedication to healthcare industry has been acknowledged, and we couldn't achieve this milestone without your support and engagement. And I would say special shout out to Elsie Gorey for her visionary leadership and hard work in helping us around our advocacy efforts as a Central Texas chapter. So Elsie played an invaluable role in achieving and helping us achieve this status. So really celebration and shout out all around to folks on the call. And then speaking of Elsie, we wanted to go ahead and also recognize that we're thrilled to share that Elsie has been nominated for, she's a finalist for the HIMSS Changemaker Award for Chapter Advocate. So Elsie is a longtime former Central Texas Board Director. She currently serves as an advisory member. And so really thrilled that we could celebrate Elsie and want to go ahead and encourage folks to vote. We included a QR code with links for more information, as well as the sign up page where you can go in, log in with your HIMSS account, and then vote for Elsie. So Elsie's dedication to advancing clinical informatics at St. David's Austin Medical Center has certainly earned, along with all of her work with HIMSS Central Texas chapter, has really earned her this well-deserved recognition. So let's go ahead and come together and show our support by voting for Elsie. The voting platform is open until September 16th, but just again, a reminder, you need to be logged in through your HIMSS account to vote. So we've got the QR code here. We'll also drop a link to the page in the chat as well. And then last little bit as well is we do have some upcoming events, chapter events we want to go ahead and put on your radar, save the date. We will be sending out more details in the coming weeks. So for folks on the advisory board, we'll be planning a social coming up in October. The date's still TBD, but we will be updating that soon. Our biggest event that we do have coming up end of October will be our fall symposium. So this will be an in-depth conversation around EHRs, health IT, and really around that age of AI. So we are doing our partnership again, and we'll be following up the symposium with a social afterwards. So keep a lookout in the HIMSS newsletter that we'll send out for more information, as well as an Eventbrite page to go and register for that event. And then, of course, in mid-November, we have Global Health Equity Week, and we'll be focusing that November Lunch and Learn around an advocacy lunch and learn. So really trying to highlight that work in mid-November. And then finally, closing out the year, we'll have our annual HIMSS forum as well. So more details will come on that. And again, keep an eye out in your local in the HIMSS newsletter for more information. And always, there are opportunities if you are attending this, any of these events. We encourage you. They are opportunities to sponsor. So I know we have sponsors that are participating as panelists, as on the webinars. Really an opportunity to highlight your organization, the services that you offer. Want to make sure that we are creating a platform for folks to get information out about the services and things that they do. So please contact our VP of sponsorship. We have included her email here, or you can go to our website for more information on sponsor opportunities. And we will be sending out some details about making it simple through PayPal for folks who are interested in that way to get engaged. So that rounds out our general announcements for today. So without further ado, I'd love to pass the baton to Dia to introduce this month's virtual Lunch and Learn speaker and webinar topic. Dia?
Thank you, Suzanne. Wonderful information. Appreciate it. And we'll get started with our Lunch and Learn for September. Thank you to Katherine. It is my pleasure to introduce Katherine. Today's topic is leveraging health information exchange to transform healthcare in Central Texas through THSA collaboration. Katherine will be presenting today. She is the Interim Chief Executive Officer for the Texas Health Services Authority, with a focus on cross-industry facilitation of secure electronic exchange of health information. The Texas Health Services Authority is a public-private partnership established to promote, coordinate health information technology initiatives throughout Texas. THSA offers a variety of services, and she does a wonderful job there. She's also has published an author and speaks at nationally interpersonally sharing her commitment to trusted information. So she has held national positions, including president of HIE and is currently board chair of Direct Trust. Katherine is a very passionate advocate for leveraging technology as a stabilizing force within the healthcare and ecosystem. The THSA, Texas Health Interpersonality, collaboratively creates a platform for stakeholders to remove interpersonality barriers. So here we go. I'll hand it over to Katherine to present today, and we'll be taking questions. Please put it out here in chat, or you can raise your hand if you have any questions. With that, Katherine, I'm going to hand it over to you. Thank you.
Well, thank you. Thank you, everyone, for having me today, and thank you for such a warm welcome. Now, I like a conversation instead of a lecture, so please feel free to raise your hand and let's have a conversation as we move forward. And I'm also going to challenge you to think as we go through here, because I want you to do some of this work. So Dia provided a little bit of information about Texas Health Services Authority, but this is the slide that I've got to go through. We were created in 2007 by the Texas legislature as a public-private entity to promote and coordinate electronic health information exchange in Texas. We have two major services, HIE Texas and Secure Texas. We also have an interoperability collaborative where we work with all the stakeholders in the state of Texas to remove those barriers. And that's primarily what we're going to talk about today, how we've worked on different things throughout Texas. We're governed by a 12-member board of directors appointed by the governor and confirmed by the Texas Senate, with 2 ex officio members from public health that sit on the board. And you say to yourself, well, what does THSA do? I know we have a lot of health information exchanges in Texas. Well, we're a public-private collaborative, and our goal is to implement state-level health information technology functions across the state of Texas. Our regional HIEs do a great job in their regions, and our national HIEs do a great job reaching across. However, who in Texas brings it all together and serves as a catalyst for change? We do, and that's what we really do. We focus on what is the change needed to support Texans, to improve the health and safety of Texans, and to cut the costs. So what does healthcare look like now? You know, healthcare has changed a lot. I'm sure all of you remember back back 10, 20 years ago, when you just went to the doctor's office or you went to a hospital to get care. That's not so much anymore, is it? Now you get care, payers deliver case management. When you go to the hospital and you go home, your payer plan calls you up, a nurse or a case manager or a social worker, and asks you, do you have any discharge needs? They've moved more into the care management space. Post-acute care. We used to think people just went to post-acute care facilities to live out the rest of their lives. Not so much anymore. They get care. Their wellness journey continues while they're in their post-acute care facilities. Community-based physicians have always been the cornerstone to healthcare delivery in Texas and everywhere, coordinating all these different services. Pharmacies. Do you guys remember when you had to go to your primary care physician or the hospital to get your immunizations? Now you just go to the pharmacy. So they're part of the care continuum. Telehealth was on the rise, but with COVID, it exploded, didn't it? And we began to see, you don't have to go to the dermatologist for a rash. You can figure out what's going on up front here in your home. And community-based organizations. And that's primarily what I'm interested in today, is talking about those community-based organizations and the future. And I want each and every one of you to think, how can we engage community-based organizations? Because as we found out, if a person is discharged from a hospital and doesn't have stable housing, they can't really recover well. So they're part of the healthcare system, aren't they? And if people are not eating right and eating nutritious food in those food deserts, they can't really do well, can they? A diabetic who lives in a food desert where there's no fresh food has some issues there. Transportation. If you can't get to and from the doctor's office, then you use the EMS system. One of the organizations that we work with, what they are doing in Longview, Texas, is trying to work on keeping people out of using the ambulance to get to and from their doctor's appointments and to the emergency room. A key element there is they don't have transportation, literacy, language, financing. All of these impact care delivery, don't they? So they become a de facto member of the healthcare system, but we're trying to figure out as a nation, how do we fit together nicely? How do we share information? How do we collaborate? Big questions ahead of us. So here are THSA services. These are our technical services. We provide emergency department encounter notifications for inpatient observation in emergency rooms. And we provide those to patient-identified PCPs and others that are HIPAA-covered entities. And you ask, how much good can that do? A lot. But we're going to talk about that. We also have Pulse, which is our patient unified lookup system for emergencies. And what that really means is during a disaster declared by our governor, such as a hurricane, we roll out an EHR Lite to frontline clinicians caring for people in alternative care sites. We also have Secure Texas, which is our privacy and security certification. So this is how HIE Texas Eden works. We get HL7 messages from hospitals, long-term care facilities, local HIEs, behavioral health organizations. There are HL7 PID messages, admission, discharged, or transfers. We run them through an algorithm, and if there is a direct secure messaging address for the patient-identified PCP, we send a message to them. We send that message to them so that organizations can meet that CMS requirement. But also we believe that if PCPs know a patient is being discharged, they can schedule those transition of care visits and they can care for that patient. We also send those messages to others with a care management relationship. For example, payers, like I talked to you earlier. And another good example is end-stage renal disease providers. They're not the primary care physician, but they certainly serve in that role. We send it to them. So different individuals that meet those treatment relationships. And this is our network penetration. We are connected to 932 different organizations, 933, because we had another organization sign on yesterday. So we're very, very excited. We cover the complete state of Texas. And the reason is we provide lightweight services that organizations can afford and try to fill in the gaps between our regional HIEs that do bi-directional and our national networks that do bi-directional. So we fill that gap between all of those organizations. So we have 161 hospitals that are live with 31 in underway. And we have a lot of post-acute organizations because as I said, it's important to include them in the healthcare ecosystem. We're also working with behavioral health organizations. We have 4 underway, 4 live, and 16 underway. So when we talk about those ADT notifications, now we're not the only ones that do ADT notifications. And you think to yourself, well, what good does it do to be notified when somebody is admitted, discharged, or transferred? Well, it allows you to increase collaboration. If primary care physicians don't know that one of their patients is in the hospital, they can't collaborate with the hospital, the case managers. They're waiting on somebody to call them back. And oftentimes when patients are admitted to hospitals, they're unnerved, they're nervous. They don't always remember who their primary care physician is, or their insurance company has assigned them a primary care physician and they don't know who it is. So what these alerts do is they let that primary care physician know one of your patients has just been seen in a hospital. You might want to follow up with them. It also allows them to know, hey, I've noticed that Katherine Lusk, one of my patients, has been to the emergency room 3 times in the last week to control her diabetes. Maybe I need to bring her in to talk about controlling her diabetes and managing her care a little bit better. So it alerts them. It's a high-level alert, not much expense or fluff with it, but it provides that basic information. It notifies other care providers that they're receiving care at your facility so that they can call you. And it gives visibility into the acute care encounters for payers, case managers, and clinics. It allows a coordination of care, and it gets us away from faxing. You know, Axe the Fax, that was one of my favorite campaigns from the ONC, and I was so sad when they stopped it because I think that getting that information discreetly and allowing it to be ingested into your EHR is so incredibly important. So why do I care? Why would THSA care about notifying people? Well, what we learn if we do our research is that in November of 2022, patient avoidance or postponement of care are common reasons for healthcare delays, for readmissions, for high ED utilization. So if we can notify primary care physicians or home health care agencies that someone has been admitted, discharged, or transferred that is one of their patients, we can help keep them out of the hospital. We can help the individuals that have knowledge of that person's clinical needs care for them. I talked to you earlier about Pulse, didn't I? Well, Pulse is the system that we roll out during disasters. And what it really does is it has a patient search function. It accesses the eHealth Exchange national network, and it pulls clinical information, a clinical history, medications, so that clinicians caring for patients in high school gymnasiums, tents, think about all the different hurricanes and where people are, where clinicians are caring for people. They're not EHRs. There's a telephone. They've got their phone and they've got a laptop maybe. Well, with a phone, a phone like this, they can call up Pulse and they can get the patient's history and their medications. Life-saving for people that are fleeing disaster. Emergency census. We ask for, when you're caring for patients in those situations, that you register them. And the reason we ask that they be registered is so primary care physicians can locate those patients. They will come up in Eden, so that home health agencies who are, from a regulatory standpoint, required to find and locate their patients during disasters, so that they can find those patients, so that they know someone is being seen in a high school gymnasium in Houston, San Antonio, or Austin. We also have missing persons, so patients and families can find one another. When families are separated during disaster, they want to get back together. So Pulse provides that ability to come back together. So here's how it works. Eden, which is the emergency department encounter notification, feeds up into Pulse, providing that ADT information as well. So they feed one another, and they're very supportive of one another. And a good news about Central Texas is Dr. Desmar Walks and her team at Austin Public Health is a Pulse administrator. They go to monthly training. They're ready in case a disaster strikes so that they can support Central Texas. This is one of the things that THSA does. We work with communities across the state of Texas to make sure your public health partners are know about the tool and are available and can use the tool in case you need it. So big shout out there to Dr. Walks. So here's what the use cases are. Disasters, people seek care in shelters, quarantine sites, and using Pulse, providers can find the medication history and their clinical history. Patients displaced. 90% of older adults disproportionately impacted by disasters take at least one prescription drug. I can recall years ago during a hurricane when I was with children's, and pediatric children would show up in our emergency room, and their families would not know what medications they had been on. Had it not been for the national networks and us being able to call up their medication history, it would have been extremely hard to care for those children, and they might have suffered. But what Pulse does is it provides that same sort of access to clinical information for everyone when they're being seen in all of these alternative care sites, even if those individuals end up in places that don't have access to the national networks. So that's why it's incredibly important to participate in Pulse and be part of it. And we're very proud of our work. So the thing that we're going to talk about most, and what I'm going to challenge you guys about, is in May of 2021, we introduced a collaborative in Texas. And what this collaborative does is it brings together stakeholders across the state of Texas, everyone, vendors, physicians, nurses, quality people, administrative people, IT people, from EMS services, from hospitals, wherever it may be, to talk about what are our barriers and what can we do to make things better. We're a convener. Everyone leaves their egos at the door, and we work on solving problems. And those problems that we work on solving are driven by our stakeholders. So our stakeholders come to us and they say, these are the problems that we want to solve. Adoption of national networks. I'll tell you how that one got started. So you can think about, do you have something you would like to solve? One of our organizations in the Dallas-Fort Worth area has a nurse call line, and they get calls from people all over the state of Texas to answer questions and to help them with their care delivery. Do we need to go to the emergency room? Do we need to go to the hospital? Do I just need to take an anti-inflammatory and aspirin? Well, how is a nurse supposed to know that if they don't have the clinical history and if they're just talking to the family? Well, if the organization they're receiving treatment at is a part of the national network, those nurses could get that information. So the vision of this group is kind of beautiful. It's wrapping the patient in a blanket of health information. Isn't that beautiful? And that means that people, regardless of where they go, their information travels with them. Because what these organizations that are a member of this work group tell me is that people travel a lot more than you would think. Electronic case reporting, we started that initiative up and increasing electronic case reporting during COVID because we found that our public health departments were really suffering, and we've done a lot of work there. Increasing use of direct messaging, you're going to love the work that we've done there. Each and every one of these products and each and every one of these services that these work group cover, they cover the entire state of Texas. Increasing use of direct messaging, that's a key point, and we're going to talk about that more. Standardizing CCDA content. Dr. Nyack from Austin Regional REC is the person who started this work group. Dr. Nyack said, as a primary care physician, the information that we are getting is inconsistent. So we worked with Austin Regional REC. I can't remember what what the official name is. Austin Regional Center. At any rate, you guys from Austin do know what it means. But Dr. Nyack started that up to standardize CCDA content to relieve the burden on our primary care physicians across the state of Texas. We have two great projects there. Immunization registry, based out of Austin, Texas. We work with our public health department and our immunization registry on how do we improve that. Standardizing newborn screening. We're working on patient naming and how do we improve capture of that data and the communication of that information. Death registry feedback. How do we make sure that when somebody expires, that the primary care physician gets notified and the hospital gets notified so that we can stop sending those notifications and we can stop filling prescriptions. Telehealth PCP notification. Now, we haven't done as much there as I'd like, but we are still trying. We have just started our behavioral health barriers to interoperability, and that has kicked off. They've had 2 or 3 meetings, lots of great work there. So here's what we accomplished in 2023. And you guys can all read this, and I'm also going to send it. You also get access to these. But as you read these things, I'm going to challenge you to go into your organizations and implement or do these things, or to pick 1 or 2 tiny things to do. Dr. Nyack led us in the initiative on standardizing the discharge summary CCDA. Austin ARC worked with Ascension and worked with HCA down in the Austin area. We looked at what does the discharge summary CCDA look like that Dr. Nyack was receiving, and what did HCA and what did Ascension think that they were sending. You know, we found out that what you think you're sending is not always accepted, and it took coordinating together, looking at the different EHRs, figuring out what we needed to do. Then we came up with a standardized content. That work group decided on a content. Then we vetted it across the state of Texas and sent out a survey where 119 different physicians answered back and said, these are the key elements that we believe need to be on the discharge summary CCDA. All started in Austin, Texas. You guys must be incredibly proud. I'm proud of you. And so then what we did after that, we met with HL7 IAT implementation-a-thon and got them to believe in us. What they said was, you have risen the bar on clinical communication. You've told us that, for one, people don't want PDF wrapped discharge summaries. They want the information discreetly. You've let us know exactly what clinical information they do want and in the time frames. And so it was beautiful, a beautiful journey. And so we worked with them. We went to 2 or 3 different implementation-a-thons, and HL7 has adopted the discharge summary CCDA as put forth by this work group, making a difference across the United States that started in Central Texas. We then commented on USCDI, and USCDI then brought that forward and said, wow, we want you to send this to the Sequoia project. Well, we did, and the Sequoia project added it to the data usability guide, and it's appendix A on the implementation guide. Is there a question?
Yeah, there are a few questions, Katherine. I did not want to interrupt you in between if you're.
Oh, no, go ahead. I got lots to talk about.
No worries, no worries. Since you wanted this to be more interactive, there are a few questions in regards to the data which you provide, especially to are the participants hospitals only clinic as well, or what about the Travis County and Texas HHS?
I don't know what Travis County, Texas this is, so you're gonna have to explain it to me.
I believe HHS is the Health and Human Services.
Oh, we provide information to HHSC. We don't, unless the Travis County, they can contact us, and if they are HIPAA covered entities, we'll be glad to do so.
Awesome, awesome.
Since I don't know their name, I bet we're not providing information to them, but we'd be glad to talk to them.
Awesome. All right, thank you. And the next one I have here is, are you currently connected to a military hospital and VA hospitals?
No, we are not connected to any military hospitals. We would like to. We're having a difficult time connecting with them. We were having some conversations with VA about increasing adoption of direct secure messaging, and I shared information from the collaborative on the efforts that they had done on increasing adoption of direct secure messaging, and the DoD and the VA hospitals in the state of Texas were rolling it out at that time. So that's been our collaboration with them. They're not sharing information with them, but we have shared information on direct secure messaging and how to increase adoption.
Awesome, awesome. Thank you. Yeah, because the next one was that what are the issues in order for getting those connections going? So that helps.
I think that the issues are people are busy.
Mm.
You know, and CMS provides financial incentives for clinicians and hospitals to connect to national networks. And so people are busy doing those things. And as they realize the value, then they connect, but they have to kind of fit it into what they're doing. To me, that's the only barrier. I've not heard anyone say they don't want to do it. And the EHR vendors are very receptive too. It's just that everyone is incredibly busy.
Awesome. So I'm
as everyone listening here is, I'm sure.
Absolutely. So I'm hearing the question that was asked from Nick. He has indicated that he's happy to work with you, Katherine, directly for the Texas VA and DoD collaboration. He can support you with that.
All right. Well, send me an email and I'd love to do that.
Awesome. Perfect. Well, I got
that will be.
No, go for it, Katherine.
No.
All right. The next one, how do the new STI regulations impact your strategy for this effort?
STI, you mean social drivers of health?
It's just HTI.
Oh, HTI. Okay. Right now they don't so much. We're such a lightweight organization that they are not really impacting us. We meet those requirements now. I know that a lot of people are very concerned about those different HTI regulations. I know that our immunization work group has been very concerned about the error messages on the bidirectional immunization and how that they will count against the EHR vendors who will then require additional elements on hospitals in Texas. And I'll explain that a little bit more. In Texas, we have a unique way of doing immunization registry that requires consenting to participate. Most organizations require you to opt out of the immunization registry. In the state of Texas, we require you to opt into the immunization registry. And there's an adult consent, a pediatric consent, and a disaster consent for adults and pediatrics. And it can be very confusing. So organizations outside of hospitals and doctors' offices don't always get these consents signed. So people get lots of immunizations that don't get fed into our immunization registry. So that's part of the reason, and reason that there are lots of issues. And when hospitals send in an immunization to the state registry, if there's not a consent there, then they can't accept that immunization, and it comes across as an error. So from an HTI-1 standpoint, that's the major issue we've been talking about. How do we prevent hospitals and EHR vendors in the state of Texas from being penalized from our consenting process? So that's the only place that HTI-1, that's probably not the kind of answer you wanted, but that's exactly the only impact that HTI-1 seems to have on us.
I see. Awesome. All right. The next question is, the CDC is currently working on a data modernization effort. Is THSA involved in any of those conversations yet, or is that still under development, largely behind closed doors?
Oh, no. We have been involved with the CDC on data modernization efforts. And we've had the CDC come and talk to us several times about electronic case reporting and birth defects in newborn registry. And we've worked with them exclusively on that, on what additional elements should be included in the electronic case reporting in CDC to minimize that administrative work for hospitals. What we found is, like, I don't know if you guys know this, but critical congenital heart defects are required to notify the State Department. People don't know about that. And there are services available for these children that are in desperate need, but the state can't find them to contact them. So what we did was we worked with the CDC, the data modernization thing, our birth defects registry group, and the state's public health department, Lucille Palanapa, who does electronic case reporting for the state, and how could we increase the use of electronic case reporting that automates those notifications to the state for birth defects. And we got them to add 12 additional critical congenital heart defect conditions to notify our state, so those children will get the services that they need in more closely into real time. So it's key. So yes, we are in conversations with them, and we try to stay so that we can know what's going on at a federal level and work with them and work with our State Department, our birth defects and electronic case reporting in our public health departments. How can we fill those needs? How can we help? Oh, I'm glad you brought that up.
No, that's wonderful. That's wonderful to know the collaboration is going on with CDC. Awesome. The next one here, please share more about the Secure Texas Security and Privacy Certification.
That was developed, and it's part of our Medical Records Act in the state of Texas. And it was developed to help give organizations just a little bit of grace should they have a breach or a leak or something like that, so that they would, and some security, to have some review to help them. Are you meeting the state's requirements for privacy and security? And it's not been as popular as we would have hoped, but we're still available.
Awesome. Perfect. Next one here. Data sharing within the network is great for efficiency and collaboration. How do you ensure data security and data privacy when sensitive data is shared? As a patient, do I have a say with whom my information can be shared?
You certainly do. You can always opt out at your local organization. And in fact, if you message THSA, info@thsa.org, we'll send you an opt-out form, and we will then opt you out of all of our programs. So you do have an option. And organizations do know, you know, there's some misconceptions about behavioral health organizations that they don't share 45 CFR information, which is drug and alcohol abuse and treatment, things like that, or psychoanalysis information. But all other behavioral health information can be shared and is shared. And in fact, CMS requires behavioral health organizations to notify the patient-identified PCP if someone is seeking services and as an inpatient, so that they can manage their discharge. How can your primary care physician manage your discharge and help you with that transition if it's all a secret?
Yeah, makes sense. Yeah, no, 42 CFR is very important and everyone should be aware of it. Absolutely.
Mm-hmm.
Awesome. And we do have a compliment for you here, your fan, David. Lots of good work you have achieved in HIT and HIM subsector of the healthcare industry. So that's a really huge kudos for you out there. So thought to bring it to your attention. I think that
Thank you.
wraps up, and I think it's just one another follow-up came off of John on the CDC, where he did indicate that it is great to hear you're engaging with CDC, such a necessary effort to bring to the industry to create some consistency at a national level, which we all know is so woefully lacking. So yeah, just a comment.
It is a comment, but you are so right on. Yes, we do. We work on normalization and consistency at a national level, so Texans aren't left behind, because Texans travel. So here are national networks, and you can see, but across the state of Texas, this is the warm blanket that increasing adoption of national networks work group talks about. We're up to 8,510 participants in national networks. 80% plus of our hospitals participate in the national network. And the ones that don't, the 20% that don't, are one EHR vendor, but they're catching up, and our behavioral health organizations. We also have great regional HIEs. And in fact, you guys have one in Central Texas, Connexus. And each and every one of our regional HIEs work for their communities, and they do a lot of wonderful, great work in their communities because they have the pulse of the community. And they know what that individual, unique culture is and what needs to be done to service their community. Here's what electronic case reporting is and how we're doing in the state of Texas. And I looked yesterday, and it looks like all of the major EHRs, Epic, Cerner, Athena, MedHost, and CPSI, Vigilant, are all up and going on electronic case reporting and can onboard. Increasing adoption of direct secure messaging. You know, direct secure messaging is the lowest baseline. So we're really working on how can we make sure that the information gets to where it needs to go. We monitor how well this work group is doing. And as you can see, the number of unique PCPs in Texas is continuing to grow. There's a toolkit on our website that anyone is welcome to utilize to increase adoption of direct secure messaging. And this is the kind of stuff that we shared with the VA. Now, it was before this, but it was before we came up with the toolkit, but this same kind of information was shared with the VA. And if you want it, just go to our website and download it. Stakeholders all put it together. It's from your frontline people, and it'll help you a great deal. Here's one of their work pages. CCDA standardization. I talked to you a little bit about that earlier. That was Dr. Nyack at Austin Regional Center. Brought that together. This is the discharge summary CCDA. If you have not implemented this in your EHR, in your organization, in your hospital, in your doctor's office, I challenge you to do it. You can improve care delivery by just using this standard. And I am so incredibly proud of it. Now, we learned from that work, from the discharge summary CCDA, that we could make a difference, that we Texans could drive things nationally. So we started working on maternal health, and this work group started out of the North Texas area. Health Centers of North Texas, which is an FQHC, and Texas Health Resources worked on this. And so what they found was that the mothers that went to deliver at THR, that they were having to go through stacks and stacks of fax documents electronically to find the discrete information. And it was just a pain. So what we've been doing is we've been working with ECW and Epic on adopting the antepartum summary progress note document. And we surveyed the clinicians to see what do we need to include in the clinical content. So we met with HL7 IAT August the 7th and 8th, and they loved it. We also then commented on USCDI 0, so maternal health, and said that we wanted people to adopt this antepartum summary progress note and the clinical content. We also commented on USCDI Plus, which was on prenatal care. This is our standardizing newborn screening, and I've already talked to you guys a little bit about that, how we worked with CDC, that work group. Here's the work that we've done with the Texas Homeless Network. We are working with Superior, the Texas Homeless Network, and C3 HIE, which is a regional HIE, and automating for Superior when one of their clients is being cared for by the Texas Homeless Network and is being seen in a hospital. And what we've been able to do there is to bring together those care managers from Superior and those care managers from the Texas Homeless Network to coordinate their discharge planning and to let the Texas Homeless Network know when people have benefits. That is so key. So THSA collaborates with nationally, as I've talked to you about the CDC and Sequoia Project and Commonwealth, and with regional HIEs. I've talked to you a little bit about what we're doing with C3 HIE stakeholders across the state of Texas. I talked to you about how that we work with Dr. Walks from Austin Public Health, Ascension, Austin Regional Center, and HCA in the Central Texas to become a catalyst for change, for adopting standards. And those standards allow us to normalize data. So our goal is to leverage technology to improve care coordination, improve the lives of Texas, eliminate administrative waste, and decrease cost. And I hope that the one thing you learn from that long list of things that I've already talked to you about, and believe me, there's lots more to talk about, there is no one single answer. There are 1,000 small things that all of us can do to improve patient care across Texas. And I challenge you to do one of these things, to join the collaborative, to pick something and to focus on that and to change healthcare delivery. Here is my contact information. Get in touch with me and get involved in the collaborative and tell me what you're doing to improve healthcare delivery. That's my challenge to you. I've shared with you what we're doing at THSA. Now I want you to share with me what you're doing.
Awesome.
So now I can see the chat. All right, what can I do to help you guys? Oh, thank you, Mo. Now I want you, Mo, to implement that antepartum summary progress note. All right, Louisa, what are you going to do? Louisa not going to answer me? Maybe. So John has said, are you coming to me, Louisa? She will in a minute. All right, so John asks, have you found working with any of the national QHINs to be more efficient and effective than others? Any unique insights about managing that data exchange we might not read about in trade journals? You know, John, I have found that all of the QHINs to be incredibly receptive. We work closely with Epic. We work closely with No2. We work closely with Commonwealth. Those and Health Gorilla, it works in our EMS service line. So no, I've not found any of them to be hard to work with. I find all of them want to do the right thing, just like all of our EHR vendors. And we just have to figure out how to work with them and to call upon them. All right, maternal care, yeah. And what's interesting about the maternal care is we also included, John, I'm so glad you're on here and asked that question. We also included those social drivers of health from Gravity in that antepartum summary progress note, so that those mothers, when they're discharged from the hospital, have those services that they need. And so that when they get to labor and delivery, they know that that labor and delivery site knows the services that the FQHC or the provider has identified the individual needs in while they were an outpatient. So we wanted to kind of coordinate that so their services are not disruptive. Yeah. Will this program also be promoted into home health sector? Yes, and in fact, I meet with I go to their regional meeting tomorrow. I'm presenting in Round Rock, Texas at their regional meeting. So on home health, yeah, because we want them to get involved, and we do have several home health agencies that participate, and we are encouraging them to participate more. I work for physical therapy EHR. Does this out with? We don't have as many rehab services that are as involved. We do have a rehab hospital. We have a couple of rehab hospitals that are involved in the efforts. And we do have some organizations that are rehab focused that work with the rural health torch hospitals to fill swing beds that are involved. We have worked with down in Houston with Baylor College of Medicine on getting some physical therapy organizations to use direct secure messaging to get their referrals. So Katherine, if you want to talk to me, I can give you a little bit of information on that and be glad to share it. All right, and so Stu. Yep, they are big. We are spreading the word with rehab, but always need to do more. What I can't say enough is there is not one single thing. It's staying constantly on it. There are 1,000 different things to do, and we all need to do them. Thank you. All right, everyone, feel free to reach out to me. Love to connect. Love to have additional help getting all of this done across this Texas. Texas is big. It's going to take all of us. So we all need to work together to get this done. Let me know. Send me an email. I'll get you on the work train with us. All right. Awesome. I think we are 3 minutes in. I'm trying to, have I got all the questions?
Yeah, I think pretty much all wrapped up at this point. I don't see any more questions. Yeah. Seems you have answered all the questions. This was wonderful session. I learned a lot. I'm sure all the folks who were attendees, they learned a lot about the healthcare and the information exchange. We truly appreciate your support and taking time to come and present today and collaborating with the rest of our folks here. So thank you so much for coming in hands and presenting. We appreciate you, Katherine. Have a wonderful day.
You too, and thank you for having me. Bye-bye.
Thank you, everyone, for joining us. And this is a wrap for Lunch and Learn today. We appreciate you attending. Thank you so much, everyone. Bye-bye.